you can actually push the pelvis all the way into posterior tilt. Yeah, so you shouldn't do that. So what you can do, last time, okay, you'll be very good.
Very good.
So you can see clearly here that there is anterior superior iliac spine. That is her posterior iliac. So clearly she's an anterior pelvic. Okay, she's like that. When I flex the opposite hip, what I'm doing is to bring it to neutral. If I push it further, it will actually go the other way. Okay, so you should just take it, flex it, so that the pelvis is vertical. So once the pelvis is vertical, you know that you're corrected for any anterior pelvic tilt. Then you measure the popliteal angle on the side you measure.
So which means that if there is too much of anterior pelvic tilt, you will get a feeling that there is hamstring tightness when none exists. Or you will
And in fact, it may be that if the pelvis is tilted too far anteriorly, the hamstrings are actually long because they've been pulled back to a more proximally based ischial tuberosity. And this is why the hamstring should not be naturally blamed as the culprit for flexing decay. Because if there is significant source muscle spasticity and contracture, if there is an anterior hip flexion contracture, if there is extensor gluteal muscle weakness, they will all contribute to the patient being unable to straighten themselves out. And then as the center of gravity moves further and further forward, they have to flex their knee in order to stay standing.
So we may sometimes falsely let the hamstring.
Correct. More often than not. So the other physical things, Jay, while she's standing there, can you all see from there, can you tell me whether her knee profile is normal or not from where you're looking at? At least the left knee, which is closer to you. Do you see where the patella is? It's riding much higher. So it is actually a very long patella tendon and possibly a contracted rectus or quadriceps above that. But that is again something to think about because it will contribute to the extensor weakness and the Duncan kneeling. Both physical findings that you actually were able to corroborate. It is one of the most difficult things to treat because if the patella does not engage correctly, the extensor power is proportionately weaker. So you can cause effect, and it becomes a vicious cycle that's very hard to get out of. And this is why some people have developed a patella tendon shortening procedure to try and bring that kneecap back down into the groove so that whatever strength there is in the quadriceps is able to work more efficiently afterwards than it was before. So I think
there is a 30-degree imperfection
bilaterally, which again is important to know. I think we should all give her a big round of applause. She's been very Thank you very much. It's been a great subject.
So I'll just summarize our clinical findings, and then we discuss quickly our management and go on to the next step. So what we've seen on clinical findings is this is GMFCS 3, where she's able to walk with support in-house and in the community. Her major clinical findings are flexion deformity at the hip of 30 degrees, which is probably because of psoas tightness. She has rectus which is contracted, and patella which is high, patella alta, with a long patella tendon. She has a knee flexion deformity of around 15 degrees. She has tight hamstrings because there is significant popliteal angle. And in the ankle and foot, she has long psoas with marginally tight gastrocnemius. Long soleus with marginally tight gastrocnemius. And she has a plano-anchored deformity in the foot with a hallux.
Just one point is I use the word tight, and this is that terminology really starts to get in the way of communication. I use tight to mean spasticity. I use the word short to mean contraction. So, but you have used tight to mean
interchangeable.
Yeah, but there is a lot of confusion and different people have their own terminology.
Use spastic and
either we use spastic and short,
Spastic
or
and
we
contracted.
use or whatever, contracted or something. So just like we use the GMFCS classification, it's very important for us to exactly say when we use non-technical terms like tight or short, we should be really clear about what we are saying.
I think the simplest way is to say spastic or contracted in medical terminology, and tight and short when you're trying to explain it to non-medical.
Let's come to management. First of all, any investigation for this patient. If anyone wants to do any investigation.
I want a hip X-ray.
Yes. And why is that?
Several reasons. She's GMFCS level 3, so the chances of there being a problem with the hip are about 15 to 20%, and we need to rule that out. Secondly, her walking pattern, she has quite a list to one side with a pelvic tilt, and that means that hip on that side is possibly uncovered. And because it's uncovered, it may be dysplastic, and we will need to know that in relation to any other intervention that we do as to whether the hips need to be addressed. Because if you end up with hip dysplasia as a walker, that hip is guaranteed to end up painful. And that will mean something in the long term that you must explain, say that this is a possibility, this is what we know from other people who are now adults who have not had the treatment in the past because nobody felt like doing anything. Now they're grown up and now they can't walk because their hips are painful. So hip X-ray. Second thing is a knee X-ray in maximum extension to see what it actually wants to get to, and in that lateral view, you would also want to see what the patella height is to check whether there is true patella alta, and also to look at whether she has any open growth plates around the knee or not, because that will give you an idea of how far away she is from skeletal maturity. One part of our standard workup would also be standing X-rays of both feet. Standing is very important because you want to know what actually happens to the feet when they are being loaded. Are the joints malaligned? Is there that midfoot break that you pointed out? Is that very obvious when she stands or not? So I would like to get these X-rays as the basic investigations to start.
So after the X-rays, any role for therapy? You think this child has any role for improvement in the current physiotherapy protocol?
Yes,
What
definitely.
would you
It may be combinations in isolation as the child is getting physiotherapy. The role of the therapist is very high before the surgery, because as we have discussed, surgery is definitely one of the part of the management plan here, because the child has got that kind of tendency. At the same time, the child has got very poor in strength, basically the truncal strength. At the same time, the quadriceps and the hamstrings are also weak, because the weakness has masked the spasticity. So the role of the therapy is, the first role should be strength training program. At the same time, how the child is moving now, because the way the child is moving is not helping the child. If we go for the gait enhancement, then we have to work on the mobility training also. It should be guarded, because the hip is showing. If the child is walking with this kind of supported, two hands supported walking, it is not going to help the child. It may be in the long run, maybe harm the child. So the role of the therapy is here, not only stretching. The role of stretching is very little, and unfortunately stretching has been done more, because the soleus is overlapped. And there are two things in cerebral palsy management. A surgeon and a therapist can go wrong, mainly with the soleus. Mainly. So here the soleus is overlapped. So stretching, the role of stretching, yes, there is the role in the hip flexors, but it should be very cautious or guarded. The child should go for strength training, the child should go for milestones, achievements, the child should go for independence training, as for example, toileting, dressing, undressing, dressing, bathing, and all these. In the mobility, the child should be, the therapist should follow the FMS scale. The scale has, basically we will discuss the scale after this session. The scale shows how the child can improve from one to the other. It is from 1 to 6. The therapist should strictly follow the mobility protocol. I hope that will be helpful to the child. Thank you.
So I could just add one more thing to say that I think of the two, between the surgeons and the therapists, I think the surgeons are more to blame for over-lengthening the soleus. I don't think we should blame the therapist, because seriously, it is probably what the child does every step of every walking day that gradually lengthens the soleus. The natural history, the therapist would not be able to do that. So don't blame the therapist. But say the surgeons definitely, if we lengthen the tender Achilles, then we are guilty, and that should not be done.
Any role for orthosis? We discussed that.
Any role, definitely, but it should not be done in isolation. So orthoses in isolation will not be effective. They will need to be used in conjunction with a surgical plan.
Any role for neurosurgery? A lot of neurosurgeons around. Anyone thinks there would be a role for neurosurgery?
Except the neurosurgeons, does anyone else think there's a role for neurosurgery? Sorry, guys.
Okay, so
no, I think she's missed
any role for surgery?
There is a role, but that role will need to be carefully explained. The best time to gain benefit from surgical correction of bony problems, muscle problems is between the ages of 9 or plus or minus 2 to 3 years. So 9 with a standard deviation of 2 to 3 years on either side. So the first thing is that she's getting closer to the end of growth, and that means that her pattern of mobility has been allowed to mature to what you see it is now. Her GMFCS level will not change. She will be a GMFCS level 3 for her life, but what she will do as a GMFCS level 3 will change. And if you look at the description in the 12 to 18 year age group, the GMFCS level 3 description suggests that they will continue to use assistive devices indoors, but there will be a greater dependence on wheel mobility outside. So at school or in the community. And that is true for a large group of people. It may not be specific to one child, but the parents need to know that this is what this scale actually means. Now, whether the child is like in any class, whether they're at the top of the class, middle, or at the bottom of the class, will decide their own individual journey. So any discussion of surgery will need this prior discussion as to what is likely to happen. Then the next question is that can you change that with any operation? And then are the risks of that operation acceptable for the benefits to be gained? And that is probably the most careful discussion to have. We would be very, very careful for one particular reason. And can anybody in the audience tell me which is the structure most at risk from going from there to there? Which structure?
LPM.
In, like for everyone else in the audience?
Later complete down.
So why not say the nerve that comes down the whole leg? So it is the sciatic nerve basically that is going to start off in a shortened position, which it has been used to because the child has been walking like that, and then an overzealous surgeon wants to do that. So the nerve stretch and the risk of a nerve stretch injury, which is pain, more weakness, and long-term problems, is the biggest risk that will need to be handled. It's not a risk that contraindicates surgery, but it is a risk that will need to be addressed. So for me, the starting point, even before we decide what to do, would be these main 2 points.
Then what to do after this?
How happy?
Well, we consider doing the source lengthening.
So psoas lengthening here,
And the rectus.
and the rectus,
And the fracture hamstring leg.
and the fraction, both medial and lateral?
Just the medial.
Just the medial. So that would be a soft tissue lengthening.
Yeah.
In your experience and opinion, what is the advantage of doing just muscle surgery in this situation?
So I think, I know probably still she will need some walking aid, but the family just say that the probably it is the more energy efficient, so that they feel comfortable with this.
Yes. So that is a very valid point, and it needs to be stressed that this muscle surgery will relieve some of the contractures that we have identified. But the downside of that, which is very important to talk to the therapist, is that it will make those muscles weaker as well. But for the purposes of what we want, weakening a hip flexor is okay because you want to work on the hip extensors to make them stronger. If you do a fractional lengthening of the hamstrings, that's okay, as long as the therapist works really hard at strengthening the quadriceps. So you can weaken a muscle that relieves a contracture, but